conflicts of we go forward. Um, let's see if we can do that. So my plan today is to walk you through treatment modality, which is upcoming. And the reason I wanted to do that was that we just started this program at WVU, and I thought this would be a good opportunity to have us talk about that new treatment modality, especially in context of a commonly seen disorder. So one of the factors which triggered my interest in this area was the widespread heart failure and stroke that we see in West Virginia, unfortunately, along with COPD. And, Dr. Stansbury and colleagues have already published quite a bit of the fact that sleep disorder breathing is under-recognized, undertreated, has significant cardiovascular implications, and in my view, it's the engine which drives many of these comorbid conditions, and it's important to recognize and treat these disorders. So I'll start with a case which will not be unfamiliar to many of you. 76-year male who's a coal miner, cigarette smoker, has some COPD, has coronary artery disease, has undergone PCA, and also has congestive heart failure. Over the years, his EF from 45%, which is on the lower end, has kind of improved to 55 to 60% with optimal treatment for his heart failure. But one of the things he consistently experiences and has several times complained about to both the cardiologist as well as primary care physician is this profound fatigue. Just not able to get up in the morning, can't do things he used to love, gardening, just going out and having a cup of coffee or on the patio. Also very disruptive sleep, wakes up every couple of hours to go to the bathroom, unable to sleep back. His wife has noted that he, whenever in between he sleeps, he quits breathing. So lo and behold, like any other such story, we suspected sleep apnea, and a sleep study was performed, and it was sleep apnea, but wasn't the usual bread and butter sleep apnea that we're more familiar with. It was a central sleep apnea, predominantly with AHI of 79.4. For those who's not accustomed to the AHI world, anything about 30 minutes per hour, which is the number of times you quit breathing, is considered very severe disease. So obviously, the first step was to consider a trial of positive airway pressure therapy, which the patient didn't tolerate, and his central sleep apneas during his sleep study actually got worse, which is not unusual with CPAP, and he was quickly converted to adaptive servo-ventilation. We'll talk a little bit about that later on, and adaptive servo-ventilation is another modality, and we'll talk about it in a couple of slides, but he was qualified for ASV treatment considering his ejection fraction. So adaptive servo-ventilation was tried, came back in 2 weeks that similar problems, feels claustrophobic with the mask, has too much pressure going into his eyes, significant eye dryness, started using some eye drops, but those didn't help too much. So what do we do? Significant cardiovascular implications, severe sleep disorder breathing, central sleep apnea, CPAP made it worse, adaptive servo-ventilation 2 weeks, and patient just not tolerating, and his life is more miserable than it was before. So this is kind of the conundrum we often face. Many of you as physicians often face this kind of conundrum. So let's talk about that a little bit. So we're talking about a very minority of patients who get central sleep apnea. The difference being that in obstructive sleep apnea, as opposed to having the airway close during sleep intermittently, in central sleep apnea, there's no drive. There's no drive to breathe from the brain itself. And we call that an intermittent neural drive to breathe. And then you get this kind of pattern where there is no movement in your abdominal muscles, chest muscles, and no flow. From the polysomnography point of view, if you can see the differences between obstructive sleep apnea and central sleep apnea, you see flattening of the waveform in all three: flow, effort, and thoracic and abdominal efforts. But in a central obstructive apnea, you'll see there's be significant effort in the abdominal and thoracic, and there's only flattening in the nasal flow channels. So this is a very important distinguishing factor. Now, central sleep apnea is not that common, so sometimes it can be missed in labs which don't see too much of central sleep apnea or significant comorbid condition. But a bigger problem to that is that this is a bread and butter central sleep apnea, but had it been a hypopnea, that's even more difficult to distinguish being obstructive sleep apnea. And it is not unusual for us to see a lot of this being mislabeled as obstructive sleep apnea, especially if you're not interpreting the studies, knowing the context of that study. So why does central sleep apnea happens? Well, one of the key reasons for breathing is maintaining your carbon dioxide. So here's your breathing center in the medulla, and basically operates as a thermoregulator dependent on the carbon dioxide. Its job is to maintain the carbon dioxide at a set level, and it gets its feedback about the carbon dioxide from all the sensors and the blood, which provides us with information about carbon dioxide and the pH. On the effexor side, it is connected to the phrenic nerve and the muscles. So if your carbon dioxide starts going up, it sends stimulus to the phrenic nerve. Hey, I want you to breathe a little bit longer, harder, deeper, so I can blow out that carbon dioxide. Vice versa, if the carbon dioxide is too low, it reduces its stimulation to the phrenic nerve, and your breathing slows down. And that's the general pattern what we see. However, the apneic threshold is very narrow. And this is a study published in Chest where we tried to figure out what's different about patients with congestive heart failure as compared to normal. And what we realized was that the carbon dioxide level in patients with heart failure is much lower as compared to people without heart failure, both during awake and during a sleep. So, if your apneic threshold is, or the CO2 level has to be maintained between 38 to 42, and normal people have somewhere around 40 to 42 levels, heart failure people hover around 38 to 40. So it is very likely that these patients, if they breathe a little bit more deeper, they will hit that apneic threshold and will quit breathing. And this is a good cartoon to show you that the reserve of carbon dioxide is so low in these patients that at the bottom, if you see the airflow and your breathing just gets a little more deeper, and then these patients do get these kind of deep breathing patterns because of pulmonary edema. And if they are hyperventilating, the CO2 dips down to that critical magic 38 number, and that allows the body to shut off the breathing. And this happens recurrently again and again, and sets into a pattern. This is the second part of the pathophysiology where the concept of loop gain is applicable to this part of the pathophysiology of central sleep apnea. Loop gain theory basically is the engineering concept which says that for any particular disturbance, if the response is more than the disturbance, which is equivalent to more than one, then it perpetuates that disturbance. In normal people, there's a disturbance, the response is much less than the disturbance, and the wave continues to die down, but not in heart failure patients. As you can see in the cartoon below, their loop gain is more than 1, and you can see the response height is much more than disturbance, and then disturbance comes back with vengeance, and the cycle continues, and that's what sustains central sleep apnea throughout the night. So the next question comes in. Of course, heart failure looks like it's very well connected. We understand why this could happen. So who are the people who are prone to central sleep apnea? What are the people we should be even aware that this may not be obstructive sleep apnea, and then these patients have a propensity to go into this unique type of central apnea? So heart failure is going to be constituting almost 50% of your patients with central sleep apnea. The next group is atrial fibrillation. So a lot of patients who may have had well-compensated heart failure, but they continue to have atrial fibrillation, they can be deceptively normal, and you may feel the heart failure is well controlled, but they may have significant central sleep apnea. The other big area or diagnosis with central sleep apnea is stroke. So it is estimated that about 8 to 10% of patients who suffer from stroke will end up with central sleep apnea. And then there's a whole bunch of idiopathic. A lot of idiopathic is morphine or narcotics derived. So we see a lot of central sleep apnea. We call that a different name called Byers breathing. And these are patients whose respiratory center has been affected by narcotics. So these are the big categories that we always worry about. So as I alluded in the patients that we discussed in the beginning, that one of the hallmarks of severe central sleep apnea is profound fatigue. So these patients have, something they'll say, "Doc, I feel my breathing is better. I feel my heart failure is better, but just cannot do anything." And this is such a vague symptom, as most of us in medicine field know, that a lot of people complain about fatigue, and there are many, many diseases which can associate with fatigue. There are many medications which are associated with fatigue. Even when you don't have those, just because you have significant comorbid conditions, you can have depression, and that can cause fatigue. So it's very difficult to figure out where that fatigue is coming from. And that's why a pretest probability, a high index of suspicion is very critical. So anytime I see a patient with congestive heart failure, patient with atrial fibrillation, patient with stroke, I pay special attention to fatigue and ask them a lot of questions regarding their sleep habits, what makes them fatigue, what can they do before, could do before and can't do anymore. So a very critical aspect of history taking in this is to dwell a lot on this symptom. Another thing which distinguishes them with obstructive sleep apnea is that these patients don't snore. So if you carefully examine and interrogate their partners will say, yes, he quits breathing, and that the thought immediately springs on our head is that it must be obstructive sleep apnea. But in obstructive sleep apnea, the pattern of quitting is that you have horrendous snoring, and then the patient becomes quiet. And in central sleep apnea, there's an absence of snoring. Now, again, these are big, generalizations. Not every central sleep apnea will follow that pattern. Why? Because a lot of patients will have a mixed disease, which is both central and obstructive. So that becomes a little bit more confusing because sometimes you can have snoring along with central sleep apnea, although a pure central sleep apnea patient will not snore. So as I said, if you have untreated central sleep apnea with the necessary background, as we just discussed, and the patient has severe fatigue, excessive daytime sleepiness, and some of them have complained about memory deficit, then your index of suspicion for central sleep apnea should be very high, and these patients are at significant health risks if we ignore their diagnosis and treatment, because there's significantly higher rate of heart failure and atrial fibrillation in these patients. They have a higher rate of readmission to the hospital, and of course, higher mortality in patients with central sleep apnea has been reported in many studies. So this is a study done by one of my colleagues, Rami Kayat, at Ohio State University, where he looked at patients with congestive heart failure and found out that patient survival depended on whether you had sleep disorder breathing in the first place, and number two, whether it was obstructive or central. So you could see that from the Kaplan-Meier curve that patients who don't have sleep disorder breathing congestive heart failure have the best outcome. Both apneas, obstructive and central, have higher mortality, but central sleep apnea has even higher mortality than obstructive sleep apnea in this context of heart failure with ejection fraction less than 45%. This is another sequel study by Dr. Kayat and his colleagues, where he looks at not only just the mortality, but a readmission to the hospital. And he found that if you had central sleep apnea diagnosed in the hospital, you have much higher rates of readmission as compared to people who did not have central sleep apnea. So mortality, morbidity, all of them are impacted by this disease. Unfortunately, a lot of treatments don't work for central sleep apnea. So this is the original CANPEP trial, which was performed to see the impact of CPAP on central sleep apnea. And, it had to be also prematurely terminated because the patients on CPAP with central sleep apnea, half of them actually showed increased mortality. And then we had a great treatment modality called adaptive servo ventilation, which is a complex form of positive airway pressure therapy. Sometimes we call this a reverse pressure support, where the machine pumps in air at the time the patient quits breathing. And that used to be the mainstay of treatment for patients with central sleep apnea until SERVE heart failure, which is one of the largest randomized controlled trial done in patients with central sleep apnea congestive heart failure in Europe, showed that it actually causes more harm than good. So patients who were on adaptive servo ventilation actually had more all-time, all-cause and cardiovascular mortality as compared to controls. And this was much more significant, or actually significant mostly in patients with ejection fraction of less than 45%. So at that time, the FDA placed a black box warning for patients' use of ASV, especially in the category of EF of 45%. And I still remember those days where we worked day and night trying to get patients off adaptive servo ventilation and trying to figure out an alternative of how to treat these patients when we had no other option in these situations. There have been other studies other than CPAP and adaptive servo ventilation, as I just discussed. There's a randomized control trial using theophylline, which is considered a respiratory stimulant. And again, the problem with theophylline is that the biggest concern is electrolyte balance and potential for arrhythmias, and it has a very low, narrow therapeutic window. So theophylline went out of favor just because of all the other side effects, and these are patients with heart failure anyway, and having arrhythmias in that would be counterproductive. Another trial showed some benefit with acetazolamide. The problem with that is it doesn't last too long. We have had several trials using just oxygen, which is what we were left with in 2016 when the black box warning for adaptive ventilation was issued by FDA. And it does show some improvement in AHI, but there was really no improvement to the daytime symptoms or arousals. So it made the physicians feel better that this patient is not dropping oxygen, but the patient didn't feel much better. So fortunately, during the same period of time, another modality was being investigated, which is transvenous phrenic nerve stimulation. And the concept behind this was, what if we could directly stimulate the diaphragm and prompt it to breathe in case the patient stops breathing with central sleep apnea? So remember, diaphragm is the most powerful muscle for us to breathe, and activation of phrenic nerve will cause the diaphragm to start contracting and generate a breath. And that was the initial concept behind this treatment. So in any way, the transvenous phrenic nerve stimulation uses very much a similar modality as a pacemaker. You can see that pacemaker is implanted right below the skin on the right side, and it has a stimulation lead, which is placed in the pericardiophrenik vein. So why is it placed in the pericardiophrenik vein? Simply because the phrenic nerves run right parallel and close to the pericardiophrenik nerve. So if you have a stimulation in that vein, so stimulator, then it would be able to go across the tissue and stimulate the phrenic nerve, which lies just next to the vein. The other was a sensing lead. And the sensing lead was placed in the azygos vein and would sit in the diaphragm to see whether the diaphragm is moving or not. And that was one of the ways we got the cue that the patient isn't breathing. In some research and more advances has happened, and now in the more recent versions of the transvenous phrenic nerve stimulation therapy, sensing leads are not really necessary if you have a strong stimulation sensor, so that decreases the time for placement of these devices. So what are the indications for that? So again, I'll keep going back that it's the context is very important. The patient has to have either congestive heart failure, atrial fibrillation, stroke. These are the major issues. We generally shy away from treating or placing these pacemakers for people who are on narcotics or abusing, morphine and other some stuff. There have been some exceptions which we have done for people who are absolutely for medical reasons on narcotics. And in those cases, they have benefited. But in general, we want to keep it very narrow to the domain which it was approved for. The big thing is that you can't use that for mild disease. So you have a central sleep apnea. We often see that 5 or 6 events per hour, and that is not necessarily an indication. Part of it generates from the reason that this trial, which was performed, used this as a cutoff. The other one is that central sleep apnea depends, the severity of it depends on the severity of the heart failure control. So if you control the heart failure very well, the central sleep apnea may actually get better. So if you had mild central sleep apnea, the hope of most of the specialists is that we control the heart failure. Hopefully the central sleep apnea will eventually resolve. Now, as I alluded to you that, yes, in book form, you can say this is central sleep apnea versus obstructive. In real life, they all come mixed up. So you'll have a bit of central sleep apnea, you'll have a bit of obstructive sleep apnea, and there'll be some events which will be hard to distinguish between obstructive and central. We call it mixed apneas. On top of that, it gets more murkier when you add hypopneas to it, which are not complete cessation of breathing, but just about 30 to 40% reduction in the airway flow. And that becomes really difficult. And I'll tell you that even in the sleep expert world, it is highly controversial. Of course, if you have a patient who has EF of more than 45, then FDA still approves ASV therapy, and we generally decide to go with ASV therapy in these patients because obviously it is not as intrusive. However, if the patient's EF is less than 45%, that's a black box warning, and we can't use ASV therapy. And of course, like in our patients, if there's an intolerance to masks, patient was intolerant to PAP therapy, we graduated him to adaptive servo ventilation patient. Despite that, patient didn't tolerate that. So intolerance to that is also a reason. What are the contraindications? It's very, very important to understand that you should never implant a device in anybody who's actively suffering from infection, because that could be a disaster. The pocket can get infected, the leads can get infected, a patient can get endocarditis and all sorts of bad stuff. So the first thing we sniff for is infection, infection, infection. So it has to be done in an outpatient, ambulatory, stable condition, not in a hospitalized condition, or when you have any suspicion of active infection ongoing. If a patient is going to be using a lot of MRI testing, whether it's a malignancy or being followed or something, that's become a little bit of a soft contraindication. And the reason is that the newer versions of the transvenous phrenic nerve stimulants are much more compatible with MRI than their prior predecessors. And of course, if your diaphragms are paralyzed, which is the basis of this treatment, you can't use it. So one of the things we always look for is, are the diaphragms working? So you get an X-ray, if it is showing there's some flattening or suspicion of paralysis, patient had some kind of a cardiothoracic surgery, lymphoma, where we think the phrenic nerve may be involved, then we do more sniff test and other advanced testing to make sure that the diaphragm is working. And this is a good slide to see that how chaotic and murky this area gets, where baseline AHI composition of the treatment in this trial, which was published in Lancet 2016. So you do see that the orange, which is the color used for central sleep apnea, appears to be the predominant theme, but you can see a whole bunch of other type of apneas pretty much in every patient of you. So that's where it becomes real tricky. The hope is that you're picking up the right patient by ensuring that more than 50% of these events were of central nature. And that's the theme behind the slide, that you got to be very careful about the picking up of these patients. Other thing which you need to be cognizant is a lot of patients use diathermy for physical therapy and other ailments, and this treatment is not compatible with that. Phrenic nerve palsy, as I alluded earlier, you need to be careful. Now, a lot of people used to think that if you already have an implantable device, that device may interfere with this device, and that can cause problem for both those devices. And that is no longer true. We generally, if the patient already has an implanted device like another ICD placed in, we generally do a due diligence and make sure that these people are not talking to each other and not cross-reacting. But in general, that is not an issue, and I'll show you why based on the experience with the original trial. So this is kind of the X-ray version of it. You see the pulse generator, which is placed right below the skin on the right side, on the right upper chest. And you see a sensing lead going on the right side. And on the left side, you see that stimulation lead going into the pericardiophrenik vein. So there's some nuances to this kind of pacemaker than most physicians and providers are aware of the experience with the cardiac versions of ICDs and pacemakers. So one of the things is, unlike pacemakers, which can be activated right there and then, and patient goes home happily after, this is not the story. This is a little bit more complex. The first thing is we don't activate this device at least until a month after the patient has been implanted with that. And there's some good reasons for that. One reason is we want to get more information. So when you implant this device and you do not activate, it's still collecting a lot of this information. So one of the things we wanted to ensure is where and when is the patient sleeping majority of the time. So sleep consolidation is very important because the therapy is pre-programmed. What does that mean? It means that it is only going to be delivered between a certain time period. So let's say, giving you an example, we pre-program the device for a patient from midnight to 6 a.m. But we won't have any concrete evidence that that's where he sleeps. And we find out in a month's time from the feedback that his best sleep time is 8 a.m. till, 2 p.m. That defeats the entire purpose because the device is active at a time which is not compatible with the sleep time. So although the patient may say, yes, I am going to bed at midnight, which a lot of people will say because the rest of the family is sleeping, what are they going to do? But they lay in the bed and they watch TV until morning at 6, and then they go to bed at sleep at 6. And that defeats the entire purpose. So it's very critical that we understand what the sleep timing are, confirm it, not just with the patient, but with the device, so that we can activate the treatment at the right time. The other thing is called the pitch. The pitch is nothing but an incline. You might have noted that a lot of patients with heart failure, they will sleep with 2 pillows, sometimes 3 pillows, because they're just not comfortable laying flat in the bed. They get short of breath. Some of them may even sleep in a recliner. So that's called the incline. And it's critical because that decides whether this patient is going to get an active therapy or not. So that pitch can be decided by this feedback from a month as to where is the genuine pitch of this patient. Even though patient says he uses 1 or 2 pillow, does he slide down? Does he wake up in the morning, put 2 more? Does he sit up in the middle of the morning? So that's very critical. And then the third is how active the patient is in the bed. If the patient is too active, that's taken as a sign that patient is really not sleeping. It's just tossing and turning. And that's cessation of breathing in the treatment. So once the breathing is stabilized, we get all of this information and we activate it. This is how it looks like. You see these central events where there's pauses of breaths, and all of that is resolved. And you can see that oxygen pulse oximeter in the top, which was undulating, and becomes much more stable after starting of this treatment. So what do we do in practical sense when these patients get this TPNS therapy? So as I alluded, critical for 4 to 6 weeks is to gather all that information, ensure the patient is educated that sleep consolidation is a must. And to some extent, it is important not only to consolidate sleep and to match it with the therapy, but that actually helps the patient because they understand that these two have to match together. So their circadian rhythm starts changing just because of the expectation from them of to sleep at a certain period of time. And then we allow about 1 to 3 months of acclimation to the therapy. What does that acclimation means? Is, when you get a strong current to make you breathe, it may be very disconcerting for the patient. And I'll tell you what the patients tell me. So if they get the current at the wrong time, and that generally happens if a patient is breathing out and then he gets a stimulus, and diaphragm being such a powerful muscle that the patient immediately has to suck back in. So it's very disconcerting if patient is halfway through exhalation and is immediately asked to pull back. So it almost feels like you're at the bottom of the swimming pool and your airway is being cut off. So very uncomfortable feeling. So because of that, it is imperative that we go very slowly on the stimulation of the diaphragm. And over the period of last 1 year, as we have planted and taken care of several of these patients, we realized that that's a combination of science and art. There is no one patient where you can start with 5 microvolts and milliamps, 5 milliamps, and then go straight to 8 milliamps. Some patients, we would have to go to 6 milliamps and go back again to 5 milliamps. And in other patients, you can go 5 and then slowly up to 8, and the patients are doing okay. So there's a lot of back and forth depending on the patient's comfort, which we look for. In about 3 to 6 months, we have to generally get them back. We interrogate the device, and if we have any concerns, we take them back to the sleep lab. So why do we take them back to sleep lab? There are a couple of reasons. In my mind, because none of them is a clean central sleep apnea. We are making a judgment call that 50% of the events in this patient are central, and that's why we're proceeding, which basically means we've left about 45% of other events untreated at that time. This leads us into another complexity that many times these residual events or alternative events may be as a result of central sleep apnea. For example, there's a central sleep apnea and there's a lack of breathing or breath generation from the brain that causes a loss of tone in the airway muscle. And there's a loss of tone of airway muscles. It collapses on itself and creates an artificial obstructive sleep apnea pattern, which is not primarily or predominantly obstructive, but is being triggered by central sleep apnea and the loss of tone. So central sleep apnea treatment can actually result in the treatment of that obstructive sleep apnea component, but I don't know that. So what I want to do is I want to go back with this with the sleep study. We not only want to titrate that, but to see what kind of apneas have I left behind, which I need to treat. If there is a substantial amount of central obstructive sleep apnea, then I need to treat that. Again, it could be a dental device. It could be a CPAP device, again, reintroduction or BiPAP, but this time with a much lower pressure because predominant amount of apneas have been cleaned, and you just clean up the rest of the apneic events. So a lot of art and science get mixed up. Let me take you quickly through the pivotal trial, which was used by FDA in making the determination and clearing this device for general use. So this is called, no pun intended, it's called pivotal trial itself. And basically, it was a multi-centric randomized controlled trial. And the endpoint basically in this was intent to treat, whether you have freedom from, first of all, 50% of the events had to be treated. And many of us in the medical world sometimes don't agree with that because we have always used AHI as 5 as the index for treatment. But in the surgical world, this is a very commonly accepted definition that as long as I eliminate 50% of the events, then that's considered a success. So again, depending on where you put the bar, that's where the treatment cutoff lies. Again, safety was a big issue. because this is an intervention with an implantable device, and we want to make sure these patients remain safe. And the secondary endpoints basically was, rapid eye movement, arousal index, how do patients feel, Epworth sleepiness score, and desaturations. So you can see that in upfront, there were 73 to 78 patients in the treatment versus control, and both the group had pretty severe central sleep apnea. You can say almost 30 events to 26 events. The reason I wanted to show the slide also was, if you look at my right-hand side of it, it says concomitant cardiac devices, which means they already had a pacemaker or an ICD placed. So you can see that even the controls, there was 42%, and in the treatment arm, almost 61% already had devices. So that gave us a lot of confidence that those devices will not interact between each other. So that is not a contraindication. These are the results, and you can see there was significant improvement in the central events from 25.7 went down to 2.9. AHI improved, arousal index improved. And then there's a whole bunch of quality of life indexes which have to do with Epworth sleepiness score. I alluded in the beginning that these patients have profound sleepiness, and that's one of the things which we want to fix, and that got better too. Surprisingly, even for me, the adverse effect were not as many as I had anticipated. So only one patient had pocket erosion, 2 patients had implant site infections, and lead displacement, and talk about that. Only 1 patient had lead displacement. So no major significant side effects were noted apart from this. This is a study which was published by Javahiri, not the original randomized controlled trial, but this was a prelude. One of the things which FDA told the investigators in this company was that we are approving this device, but we want you to continue to collect data for over 5 years period of time. And you can see that with this data, that the central sleep apnea resolution, which was noted at the time of the beginning of the trial, continued to persist as long as 5 years down the road. And there was sustained improvement even in the sleep architecture. Now, one of the things we noted with this device was there was a significant increase in REM sleep, which is the dream sleep, which is very healthy for humans. And also, if you can notice that the N1, which is the superficial sleep, actually went down, and the N2, or which is called the core sleep, actually went up too. So both improvement in N2 as well as REM were noted. This is more of a post hoc analysis, and I would put this data with a little grain of salt, but it did show that there may have been a little improvement in the ejection fraction in about a year's time in these patients, and there was trend towards reduced hospitalization, but no impact on mortality. So suggested approach of treatment for central sleep apnea based on all the data that we have, the information that we've gathered so far, is that the key thing is to optimize heart failure. As I alluded earlier, if you really control heart failure, you can change and sometimes even eliminate mild central sleep apnea. But what if there's persistent central sleep apnea? What if they had moderate to severe central sleep apnea, which you couldn't eliminate? But in this case, you have 2 choices. Your choices is you look at the ejection fraction of these patients, and you find this patient has ejection fraction of more than 45%, then those patients would still qualify for adaptive servo ventilation, and that's what we do. And we see whether they are responsive to it, they tolerate it or not. And based on that, we will offer them continued ASV or counsel them whether they probably would benefit from phrenic nerve stimulation therapy. And of course, if your ejection fraction is less than 45, you have no option but to consider phrenic nerve stimulation in this situation. So a few slides on our own program over here. So this was a real case which I presented in the beginning for you. This patient did not tolerate adaptive ventilation. We had a good talk with them. He understood the pros and cons of getting this pacemaker, and his fatigue and symptoms were so profound that he felt that this is the step he would needed to take. And we obviously got this patient, got them implanted. They come back in a month's time, and we interrogate the device. We look at the pitch, we look at the sleep time, we look at the current which they're going to be using. This is what we did for him. This is his chest X-ray. You can see the implant on the right side, and you can see the stimulation lead. One of the things we do for patient protection is we leave one of the sides as the safe sides, which means that if the patient start having significant problems with this electrical stimulation that he cannot tolerate, then we'll have one side in which the program terminates no matter what. So this patient, if you can see, the right side of it is the safe side. So we encourage people that anytime you feel uncomfortable because the device, just switch over to the right side and it'll all terminate by itself. And you can see that there's a weekly titration. So it kind of starts simulating more and more each week, and goes up very, very small doses of 0.1 milliamps per week. So this is what the patient told us about 3 months down the road. I no longer fall asleep at inappropriate times. I have more energy. I am able to get back to gardening, which I missed due to my illness and fatigue, and no longer use eye drops for dryness, which was a constant feature with both CPAP and ESP, and able to enjoy watching TV programs with my wife without falling asleep. So a success story. This is, he gave an interview to our local newspaper over here. So that's about him. So that's why I'm able to show him to you guys. This is interesting second case where, we learned that everything doesn't go exactly the way it is supposed to go. So this patient also had heart failure. His EF was less than 40%, so we had no choice but to consider pacemaker. Patient understood the pros and cons of and adverse effects that might happen, opted for it. And you can see that he already had an ICD pacemaker already placed in, so this was a dual device for him. We looked for compatibility, and it was fine. And then he came back in a month, and we saw that it was a complete flat. He was not registering any kind of impact on 5 milliamps, and we didn't know why he was not triggering it. And his pitch was fine, everything is fine, but look at this, his current wasn't stimulating anything. And then we got a chest X-ray done, and you can see that his lead had withdrawn. So as you see, that lead is withdrawn. So one of the things we learned is the leads which are placed in for patients with this transvenous phrenic stimulation, they're not tethered. So it's very important for these patients to be counseled that you cannot be extending your arms for several weeks period of time. You can't do stretching exercises, and anything you do which stretches and untethers that stimulation lead, then it'll be pulled back and it won't have an impact. Fortunately, in this case, we didn't have to go in and relodge the case, but increasing the current appropriately to a little bit more supratherapeutic level started capturing, and the patient started receiving the treatment, and is doing very well now without any further intervention. So take-home message in this is that there's significant advances in alternative therapies have occurred in sleep disorder breathing. This is a big boon to the patients in West Virginia who have profound level of heart failure, atrial fibrillation, and many of them by default would have significant amount of central sleep apnea, which goes completely untreated until so far, just because we have no other treatment options. This is age of precision medicine, so it's understanding of the subtypes, what kind of apneas you're dealing, what kind of treatment would fit best with that particular treatment is very important. And, for now, WV is the only center offering a venous phrenic nerve stimulation for this. So with this, I thank you for listening. I think I may be right in time. Hopefully get some questions in.
Thank you, as always, Dr. Sharma, for a wonderful presentation and so much great information in there. But yeah, we'll open it up for any comments, questions from the group. I'll do a nice little echo pause here. Dr. Ward?
Good morning. I have a quick question. And this is Carl's weird physiology question. And that is whether you mentioned that central sleep apnea, the basic problem is that there's a reset of the CO2 sensor in the blood, functionally. And my question is, has anybody ever tried supplementing CO2 to see if that might be a treatment option that's somewhat less invasive? I realize you'd have to be careful not to asphyxiate your patient, but I'm just curious if that's ever been tried. Go ahead.
Yeah, and that's an excellent question, is that I actually, in my younger days when all of these treatments were not available, had a dentist who had profound central sleep apnea. We did everything, even talked to my mentors who he had done 20 years. We couldn't figure out what to do with him. So basically what I did was I put him on just the mask. And you know how the CPAP mask have an exhalation port? And that is to blow out the CO2. Because, I started covering small of those dots with face tape, one by one. And what it did was that increased the CO2 levels, which he was breathing out. And we saw that his central sleep apnea started disappearing. He was like the only successful case I have treated in this very bizarre way. But I think physiologically it makes sense. The problem comes in, you cannot modulate it. You cannot modulate how much carbon dioxide you're going to do, how much dead space you need to create for that particular person to resolve the central sleep apnea without putting him, as you said, in a situation where you may asphyxiate. So we haven't come up with that kind of a protocol yet.
Yeah, I mean, what I was envisioning was almost where you would like give the person. I mean, if you get over 1% CO2 in their inhaled air, you cause really weird psych things to happen. But because we always have, there's, I don't know, between 300 and 600 ppm CO2 in the air that we breathe now, depending on where you live, how close you are to a coal-fired power plant. But the question, my thought was be like, could you give somebody, I don't know, 1,000 parts per million inhaled CO2, like via nasal cannula or something simple, just to kind of reset that. It made this, and then you can, and if you use a device to do it, you might be able to modulate it in a way that would be, you could adjust it to therapeutic effect. I don't know if any of that works. It's just one of those thoughts, random thoughts. So thank you for sharing.
Yeah, no, I think it would work. It's just that I think the operational word which you said is modulate. Can we modulate without harming that patient? I think that's where it gets very tricky. As you said, that even a slight increase in CO2 can have devastating impact on those patients. We see that all the time, CO2 narcosis, getting admitted to the hospital and they become woozy. So how are we going to monitor that at home when we can barely monitor that in the hospital setting? But yeah, when I was younger and a little bit more brash, I tried that kind of treatment. I wouldn't try that again. But I think that if you come up with that, you probably could win a Nobel Prize for that one. Thank you for the excellent question, though.
Yeah, thank you, Dr. Werns, for your question. Any other thoughts from the group, questions, comments? And you're welcome to chat in, and I'm happy to read any chats that come through as well.
Sure.
I know we are at the top of the hour here, but any final last comments you wanted to say to the group, Dr. Sharma?
I thought I really put the group to sleep, so great that everybody caught up within an hour of sleep. We're always sleep deprived. But thank you again. I'm open to emails if you have any questions regarding that. Even if you have a patient, you suspect of central sleep apnea, needs further evaluation. These are tricky situations, so they are not bread and butter obstructive sleep apnea. Please be happy. I'll be happy to walk you through. So thank you again, and thank you for the opportunity to talk to you guys.
Absolutely. Thank you so much. And we're getting chats in from folks thanking you, saying it was very, very interesting, great presentation. So, and we did get another chat in from someone who was having some connectivity issues, and he actually emailed me saying he's going to go back and watch the YouTube video on the parts he missed. So just wanted to let you know that as well, Dr. Sharma. But I appreciate you all very much for joining here today. And Dr. Sharma, thank you again for presenting us for us today. Only announcement that I have is that the next session will actually be on December 18th. Dr. Weissman, we have you down for spirometry interpretation. So I believe the November one is canceled due to the holidays. So wish you all a wonderful Thanksgiving. I know that's still about a month away, but next time we'll see each other is in
Happy
December.
Halloween too.
Yes, happy Halloween as well. Exactly.
Take care.
All right, take care, everyone. Thank you.